Hello everyone, welcome to Medicine with Sazan. Today I'm going to share how I passed my MRCP UK exam and what was my overall experience. I will also be sharing my feedback form and how I passed each skill and each station. PACES is one of the most dreaded exams in the world. All exams, of course, by nature are dreadful, but the thing with PACES is that the candidates who are appearing for the PACES have already been held out of exams. And most of the candidates also have years of clinical experience. Still, they are unsure whether they will be able to get through this one or not. And other thing that adds to this scariness is that this exam costs hell lot of fortune. So a lot of your investment is at stake. I was scared from exam too, of course. In fact, I started having so much exam stress that I suffered from stress-induced diarrhea. But I'm not that kind of person who keeps cramming the books even at the last moment. In fact, I threw away my books 1 or 2 days before the exam and try to chill out and try to have a full night's sleep, which I did. On the exam day, I had a cup of coffee to stay alert and sharp. At centers like ours, like in Pakistan, each day 2 or 3 cycles are run. So my exam was in the third cycle, like in the evening, and my report time was 1 hour before the exam started. Like if my exam was about to start at 5 p.m., my report time was around 4 p.m. Still, I reached there at like 3:30 p.m. to have ample time to adjust myself to the exam condition. We were 3 candidates in that cycle. Ideally, there should have been 5 candidates, but as I have mentioned, it was the last cycle, not of the day, but in fact of the exam session. Like in Pakistan, the PACES exam runs for like 4 to 5 days. So it was the last day of the exam session and the last cycle. So ideally, there should have been 5 candidates, but in our cycle, there were only 3 candidates. We had a little chit chat to relax ourselves, and 1 hour before the exam, we were called in. Well, that time runs away like this 1 hour because it's our responsibility, the candidate's responsibility to fill in their feedback forms. Feedback forms are the sheets where the examiner marks you in each specific skill and also gives their feedback. So it's your responsibility to fill in your biodata, like your RCP code, your exam number, the center code, all of that. And there are 16 such forms. So one goes away like this, right? So like you have exam stress in one hand and 16 feedback forms in your other. The organizers tried to make us feel at home and even offered us any water, tea, or coffee. But you see, like I mentioned, when you have exam stress in one hand and feedback forms in other, you don't even care if you want to go attend the washroom or not, let alone the water or the tea or coffee. 10 to 15 minutes before the exam, the chief examiner came and tried to give us some relaxing talk. But when you have exams starting in like 10 to 15 minutes, you cannot even focus what he is saying. But to be honest, half of the things he said were untrue because he was like, most of the exam cases today are the ones you see in your daily routine, which is completely untrue. Because to be honest, if that was the case, the purpose of the exam is not fulfilled. It kills the purpose of the exam. Like even if I was the examiner, I would try to select a case which is unique, which is special, not something you find in your daily routine, right? So a few minutes later, our exam started, and my exam started from station 2. In PACES, there are 5 stations: station 1, 2, 3, 4, 5, right? And you have to run in a cycle. And the station, each station consists of a room, and you have to sit outside for like five minutes. There may be some scenario given. You need to go through it, write down your notes. You can take the notes inside when you go in, but at every station, you sit outside for 5 minutes and then you go in. So my exam started at station 2. I was handed in a piece of paper where the scenario was written. Station 2 consists of long clinical consultation. And my scenario was, I don't remember the exact details or the age of the patient, but there was a young patient with 2 week history of tremors. I don't remember his vitals, but I can assure you they were completely all right. So when I read this information, I was completely blank. I don't know what. Again, the exam stress. It took me a while, a few moments, to bring myself back into the exam center and try to focus. So tremors. In PACES, when you read the chief complaint, you cannot think of all the diagnoses. Like in case of mine, the tremors, I cannot think of all the different conditions that can lead to tremors. I can maybe uh, selectively go through the major systems, but I cannot go through a review all the conditions that lead to tremors. In fact, if you can just stay calm outside for 5 minutes and go in, start taking history, only then when you start accumulating some clues, only then you can uh, pinpoint where your direction is, where which path you need to take to exactly reach your diagnosis, right? Still, if you want to make some notes outside in those 5 minutes, you can touch the major system, review the major systems, and when you go inside, you can in the first few minutes you can go through those systems, ask those important questions which you need to ask, and then as clues accumulate, your path, your direction will reveal itself. Anyways, in my case, I wrote down the major systems which I would be reviewing, like neurological system, essential tremors, then physiological tremors, juvenile Parkinson's, and so forth. Then endocrine system, like hyperthyroidism, pheochromocytoma, and conditions like that. Then thirdly, drugs, as you can see, 2 week history of tremors, so drugs could be the cause. Now that's it. After 5 minutes, I went in. There were two examiners sitting behind the table. The surrogate was sitting in front of me, and the patient was sitting behind the surrogate, just by the door. In exam centers like Pakistan, you need to take history from the surrogate, not directly from the patient, because oftentimes the patient cannot speak in English. So you need to communicate with the surrogate and ask questions in English, right? In my case, my path was sorted out right in the beginning, because when practicing this clinical consultation scenario, I made this my habit to quickly screen past medical and surgical conditions. Only screen them, not go into the details. I would go into the details later. So when I quickly screened them and asked the surrogate if the patient has any previous medical or surgical condition, they immediately told me the patient had undergone liver transplant and was on this medicine, including tacrolimus, right there. My path was set right there. This patient had undergone liver transplant, non-tacrolimus, maybe due to drug interaction or toxicity of tacrolimus. He is now having tremors. Still, that was 90% of my diagnosis. Still, sometimes 10% can override that 90%, right? Exception sometimes can be the rule. So I had to roll though that 10% conditions too. So I followed all my history taking scheme to rule out hyperthyroidism, essential tremor, juvenile Parkinson's, and all of other different conditions that could be related to that scenario. Then I examined the patient, followed all the tremor scheme, ruled out fine tremors, resting tremors, essential tremor, even ruled out any rigidity, bradykinesia, ruled out any palpitations, did their whole GP, and then came to examine their abdomen and examined their abdomen thoroughly. There was Mercedes-Benz scar, and liver was not palpable, splenomegaly was not palpable, no other signs. When 2 minutes were left, the examiner alarmed me and I left everything and came to address the patient's concern. Make this your habit. When only 2 minutes are left, you should leave everything, and in such in situations, leave everything out and come to address the patient concerns because they carry equal weightage. When 15 minutes passed, I addressed the examiners and started presenting my case, formulated my top differentials, and mentioned how I will manage such case, on which the examiner asked if I would like to send thyroid profile to rule out hyperthyroidism. I said yes, of course. Mentioned the thyroid profile, which test will be needed. But I mentioned still it is down the list of my differentials because I have already ruled that out on my history and examination. At which he asked how I have ruled hyperthyroid out. So I mentioned I asked about weather preference and the idea of palpitations. And on examination, I ruled out fine tremors, any palpitations. I didn't rule out any eye signs or goiter, but he didn't much probe into that. So that was it. That's how my first station of PACES exam concluded. And I passed this station with full marks, as you can see in my feedback form. Going on to my second station, that was station 3 of the exam cycle. In PACES, station 3 consists of two substations. Station 3A, where you need to examine CVS, and station 3B, where you need to examine CNS. When you're sitting outside station 3, you don't have any, you're not given any information because that is a short case scenario. You just sit there, maybe drink some water, that's it. Maybe revise the scheme of the examination. That's it. You don't need to do anything else. The short case scenario consists of 6 minutes of examination and 4 minutes of viva. So when I was called into station 3, my time started right there. My 6 minutes of examination, including examination, started right there. I went in, I exposed the patient, asked them to take off their shirt completely, pull their trousers up to their mid-thigh, and right there, I saw mid-sternotomy scar and a scar on their tibia. I don't remember which side, which tibia, but there was a saphenous vein graft scar. So I knew right there it is a case of scabbage with some sort of valve replacement, as I could hear a metallic click without stethoscope. But in this scenario, in this station, you need to exactly pinpoint which valve is replaced to score fully in this scenario, in this station. To pinpoint whether it is mitral valve replacement, aortic, or dual valve replacement. Otherwise, you are not going to score well in this station. So I started examining them, examining their general physical examination and examine their precordium. When I started examining their precordium, to be honest, I could hear only one sound, that was the click. I don't know why. There was only one sound, and that was a click. And the issue with this thing is you cannot exactly time it with the arterial pulse. To top it off, when I tried to palpate their carotid, I couldn't properly palpate it. I don't know why it was the case, maybe exam stress, exam pressure. I focused all my energy onto it, all my skills onto it, but I couldn't figure out which valve was replaced. So I had to improvise something. Since I couldn't palpate their carotid, I started palpating their radial artery. And after some time, I could feel that there was some gap, like millisecond gap, between their radial pulse and the metallic click. The metallic click was coming like milliseconds later than the radial pulse. So, like I was 70% sure that might be aortic valve replacement, but I wasn't completely sure. I don't know because it was because of the exam stress or the examiner standing just right beside me. Another thing that made me think of aortic valve replacement is while when I was practicing with my study partner, we made it our motto that after seeing a lot of patients, we made it our motto that if you cannot figure out whether it is mitral valve or aortic valve or dual valve replacement, just go with the aortic valve. That was our motto. After examining a lot of patients, that was our result. So I went with aortic valve replacement with cabbage, and I passed this station 2. That was my feedback form, as you can see here in this feedback form. Going on to station 3B, the neurological station. As soon as you leave station 3A, CVS, your after the Viva, your time for CNS starts right there. Your 6 minutes start right there. So you have to practice a lot before the exam to manage your time. The scenario was mentioned on the wall on a piece of paper, difficulty walking. I started my examination. It was a case of spastic paraparesis. When I started examining their sensory, I could see there was sensory level. It was asymmetric sensory level. It was present on one side, but not on the other side. And same was the case with the reflexes and tone. So it was a case of asymmetric transverse mellitus. But I mentioned other differentials that could present with spastic paraparesis with sensory level. So I passed this station 2 with full marks, as you can see in my feedback form. Going on to station 4 of the cycle, my third station, it was communication station. Now, communication stations also consist of 2 substations. One is the communication, another is short case. Station 1 is also communication, and it is along with respiratory examination. Station 4 is also short communication station along with short case of abdomen. At station 4, I was given a scenario outside, and I had 5 minutes to read through it. I don't remember all the details. In fact, I shouldn't mention because of RCP code of conduct. But it was a case of palliative care. Some cancer patient was reviewed by multidisciplinary team, and they came to the conclusion that they should be putting the patient on palliative care. And I, as a doctor, was to inform his son and deal with their any questions or concerns. So I made the notes outside the station, and as soon as I went in, my time, that there is 10 minutes in communication station, and there is no Viva. You just speak with the patient relative or surrogate, whatever it is. That's it. In those 10 minutes, you need to communicate with them, address their questions, concerns, and that's it. The examiners are looking over you. They don't give any input, and they don't ask any question at the end of these 10 minutes. As soon as 10 minutes pass, you move on to your next substation. Like in station 4, I was supposed to move on to examine the abdomen of the next patient, right? So as soon as 10 minutes of my communication started, I went in, and after introduction, I followed the spike model of communication, touched the setting, perception, invited any question and inquiry to assess their knowledge, and asked how much they want to know and all of that. ask them any concerns right there, because that helps to sort a lot of things out. Also set the direction. It sets the direction where you should be leading the conversation. Anyways, I applied the principles of palliative care in that station, whatever I have learned in my preparation time. And to be honest, that patient was a little fussy. I don't know how I should put it, but he couldn't even let you speak even a word. And I was so much tense at the end of this scenario that I was sure that I would fail this station. Still, I passed this station with full marks, and here you can see my feedback. Going on to station 4B, it was abdomen. So I did my GP. I first of all, of course, exposed the patient and started doing my GP. And right there, while examining him, I could see he has lymph nodes palpable. Also, he had gingival hyperplasia. When I came to examine their abdomen, their spleen was enlarged. So, putting it all together, I could see it might be linked to some hematological disorders, most likely myeloproliferative disorders. I mentioned that, and all of those things. In that station, I don't know, because of stress from the previous communication station or anything else, I couldn't fully determine whether liver is enlarged or not. But I came to realize the liver was enlarged. And also, one other blunder I made at this station was the patient had undergone excision biopsy of the lymph nodes, but I couldn't put it completely what it was. Anyways, they cut out some marks, and still I was able to get through this station. Here is my feedback. I hope you're enjoying this video and my experience. For rest of the stations, stay tuned.